Let's talk about congenital hypothyroidism. This is chapter 48 in your Ricci text. All right, so disorders of the thyroid gland are super common in infancy and childhood. Um, like we've talked about, your thyroid hormones regulate the metabolism of all nutrients and energy production. So try to wrap that into your thought process when we talk about congenital hypothyroidism, that they are lacking in the hormones needed to metabolize nutrients and produce energy. So any information about congenital hypothyroidism starts on page 1789 in your Ricci text. It's described as a malformation or a malfunction of the thyroid gland leading to insufficient production of the thyroid hormones. So this can be due to a spontaneous genetic mutation. It can be due to an autosomal recessive trait that makes the thyroid hormones not synthesize. It can be due to an inborn pituitary dysfunction. It can also be due to a CNS thyroid feedback loop that doesn't develop. So there's a lot of reasons why congenital hypothyroidism can occur, but it's not usually something that is done by, like, it's not a maternal exposure type thing. Luckily, we do find it on most newborn screenings, which is good. So we're looking for low concentrations of circulating thyroid hormones that include T3 and T4. So this occurs 1 in every 2 to 4,000 live births, which is pretty common. It does affect all ethnicities, although it is not as prevalent in African Americans. It is more prevalent in girls than boys, and it is not usually hereditary. Okay, so the complications that can occur from undiagnosed or untreated hypothyroidism in a neonate is that they will grow to have severe intellectual disability. They will be short in stature. They will have growth failure overall, short arms and legs, and they're also going to have delayed physical maturity and delayed physical development. Um, the later we start treatment, the more of these things we're going to see. So the management of these little ones is that we're going to give thyroid replacement. So we use things like Synthroid, thyroxine, or Levothyroid, and we start at about 10 to 15 micrograms per kilogram per day. And we do thyroid function tests every 2 weeks for a few months of their life until we can get some really good therapeutic levels. Um, we do need to make sure that families understand that this is a lifelong thing. They're always going to have hypothyroidism, and they're always going to need to be treated for it and tested. So the cues that you're going to see in a child or a neonate that is born with congenital hypothyroidism is they might be sensitive to cold, which frankly we might have a hard time proving that until they're a little bit older, but we might see discoloration of the extremities that occurs longer than we expect it to. Like, you know how neonates, they have little purple or blue hands and feet that goes away within the first couple weeks to a month. We might still see it in these little guys. They're going to have constipation. feeding problems, usually due to their very enlarged protruding tongue. They're going to be lethargic. Hypotonia is going to be something we see, as well as just an overall hypoactivity. And this is all related to the lack of energy being maintained by their metabolic activities. They're going to have short necks, shorter than other babies, and limbs. Their arms and legs are going to be short and squat compared to their torsos. They're going to have some puffiness around the eyes and, like I said, protruding enlarged tongues, which makes it hard for them to feed both at the breast and by bottle. And frequently they're going to be bradycardic. So, we look at the diagnostics, we do newborn screening, and then we can also do thyroid function panels. So we expect to see that the T4 is very low, the TSH is elevated, and then we might do a thyroid scan just to prove it to ourselves. And the thyroid scan is going to show either an absent thyroid or what's called an ectopic thyroid. Basically, it didn't migrate into the area of the body that it was supposed to during fetal development. With the newborn screening, we really don't want to do the thyroid testing within the first 12 to 24 hours after birth. We want to do it 2 to 4 days because in the very beginning, the first 12 to 24 hours after birth, the maternal thyroid hormones are floating around and circulating in that baby. So we want to wait until they've been able to metabolize or get rid of some of the maternal blood. Okay, our actions as nurses. We are going to check the blood pressure and the heart rate before every dose of levothyroxine is given. We are going to administer the med at the same time every day, and this is also education that we're going to give to the families. We are going to do daily weights on these babies while they're in the hospital, and we're going to do strict I's and O's. We're going to report any cues that lead us to believe they might have toxicity or overdose of the medication. So the things that we look for that are signs and symptoms of overdose are irritability, rapid pulse, dyspnea, sweating, and fever. Those all show that they've received too much of the hormone. If they're not receiving enough of the hormone, we're going to note fatigue, constipation, decreased appetite, and poor feeding. We are going to educate the family about staying away from iodine-containing foods, and those are things like soybeans and turnips and tofu, and to not use iodized salt. They can use some other form of salt. And then we want to educate them on the fact that, again, this is lifelong management of these little buggers. They're going to be on medication every day for the rest of their lives, but there aren't going to be any complications once dosage is found to be an adequate level. So as they grow, they'll continue having labs done, and we will change the dose based on the growth that they're having. But other than that, they should be normal, healthy, fully functioning children without any of the complications of intellectual disability, as long as they are continuing their management. So unfortunately, medications like levothyroxine are not available in liquid form. They're only available in tablet form. So we do let families know that it's okay to crush up the pill, and they can mix it with formula or breast milk. They can suck it up into a little tiny syringe and they can squirt it in the baby's mouth and make sure that they take it. There's little tips and tricks that we can give them, like to put the nipple of a bottle in their mouth, kind of like a pacifier, and squirt the medication through that so that they can kind of suck and swallow at the same time and they're less likely to spit any of it out because we want them to get every bit of that dose. We don't want them to crush up the pill and put it inside an entire bottle because we can't guarantee that that whole thing is going to get um, taken. So we want to make sure that they take it at the same time every day. So just little bits of formula mixed with the pill, little bits of breast milk mixed with the pill, squirt it through a little nipple um, from a syringe. And there you go. And these are the goals for treating a child with congenital hypothyroidism. We want to, as much as possible, promote normalcy. So normal growth. We want to promote adequate hormone replacement and avoid all of the complications of lack of or undertreating. And that means we really want to educate the family a lot about the signs and symptoms of overdose and underdose. We want to decrease the risk of hypo or hyperfunction by doing exactly that, making sure that the family knows what hypo and hyper looks like, what too much and too little looks like. And then, like I said, we're going to educate the family and we want to make sure that they can successfully use resources that are provided to them, like labs and medications, pharmacies, specialists. We might need to have these kids, depending on how they grow and the structure of their face and their mouth. If they took a little while to be treated, they might need to have speech therapy or occupational therapy involved in their life. So we just want to make sure that we get them the resources that they need and promote their normal, healthy childhood.